Comment section of my last video on the difference between carrier screening versus PGT is blowing up. And so my suspicions were correct that there is a lot of confusion and there needs to be way more education when it comes to the topic of genetic testing. So I'm going to try to tackle as many of the really high yield, important questions like I get asked all the time by my patients that showed up in the comment section with their own dedicated video. This question about what is the difference between a karyotype and carrier screening is so important. So carrier screening, just to review, is where you're looking in both the parental DNA from a blood sample at a certain list of defined gene mutations. And these are mostly autosomal recessive or X-linked, meaning this isn't looking for a problem in your health, but trying to understand a risk assessment of if you combine your DNA with someone else's, a partner or a donor's, could there be a risk of having an affected child? A karyotype is very different. It's actually a blood test, and it's done in a way where cells are isolated and stained so that the chromosomes show up, and you are imaging the chromosomes. You're taking pictures of them, and chromosomes are basically packages of DNA. So you have your genetic code, and it's wound tightly into packages called chromosomes, and they come in pairs. And so this is a much more zoomed out view of your DNA to say, is there anything structurally going on where there could be a section of a chromosome or a whole chromosome that's missing or duplicated, or even sections of it that are missing or duplicated, or even translocated or inverted and flipped. And the reason why we do this test, it's not a test that we do across the board for every patient, but I will typically do it in patients with recurrent pregnancy loss because you're trying to understand, does one partner or the other have a translocation or a chromosomal rearrangement that inherently puts them at risk of forming embryos with their partner's sperm or eggs that could result in a higher than expected rate of errors, imbalances, aneuploidy. And so both partners, it's very important. Sometimes I see it where only the female partner has had her testing. Both partners should do the karyotype testing if the workup is for recurrent pregnancy loss and ruling out translocations. We also will do this often in cases where none of the embryos make it to the blastocyst stage. There's just so much drop off, and it doesn't make sense why there would be that much drop off. You're expecting better conversion rates for that patient's age. I often will do it if there's really high aneuploidy rates. And in the aneuploidy report, if we're seeing really distinct patterns that are suspicious, making us suspect that there could be a chromosomal rearrangement. So if you're seeing a lot of involvement of chromosome 14, 15, 21, 22, and it's repeated over and over, that's when you want to do a karyotype on the parents to look for that translocation. I also will do it just on the individual patient. This is not a couple thing. If they have extreme DOR, especially in their 30s, way earlier than expected, for anyone with POI, primary ovarian insufficiency, where the ovaries just stop working, premature menopause, because you want to look for genetic causes like there's something called Turner's mosaicism. So you want to look for an issue where some cells of the body might be missing the X chromosome. So people could be walking around with that, thinking they're totally healthy, and maybe they are, but this is how it can manifest. So those are a couple of the examples of why someone would need a specialized test called a karyotype. It is a genetic test, but it's very different from carrier screening. I hope that helps.